Okay, so ultrasonography actually gives us morphologic changes, but no information about function of nerve fibers. This is very important. If we compare it with the function of a tendon, we actually only see morphologic changes. And that's the reason why ultrasonography findings of nerves are only valid in correlation with clinical symptoms. This is similar to MRI techniques. As you know, we often use MRI to get actually findings that are not correlated with the clinics. And nowadays we have the MR neurorrhaphy that actually is more sensitive than sonography because of the use of diffusion tractography. We actually can also show nerve lesions very nicely, localize them, and maybe in the future also be able to see nerve regeneration better than probably with ultrasonography. However, conventional MRI and ultrasonography are similar in the specificity with a better sensitivity of the ultrasonography because we have the chance to follow peripheral nerves with our tracer directly along its course, whereas MRI only shows us selective sections, and this is not always corresponding with the whole course of a nerve. So neurosonography is, the anatomy is as well as everywhere in the sonography very crucial. But we have one good thing in the hand and in the legs. We have actually the possibility to compare our findings with the healthy or uninvolved other side. And please use that always, because you get a good comparison and you learn a lot about what is normal and what is abnormal. Then, as I said, we want to show a couple of things, morphological changes in injured nerves, especially neuromas. And also what is nice to follow is the postoperative course after nerve reconstruction or nerve repair with sonography. I want to show two examples of a diagnostic and therapeutic infiltration in nerve lesions, and finally some aspects of nerve tumors and other lesions. The texture and the gliding capacity of a nerve is very good to see. You see here, when I get my arrow, yes, here we are. You see here, this is the typical longitudinal structure of a healthy nerve. This is an ulnar nerve, this is the ulna here, and you see the single fascicles, whereas in the cross-sectional area on this side, this is more difficult in this aspect, but the cross-sectional area or the transversal section, a healthy nerve shows like a salami slice. You see the white dots of the axons. This is the second aspect of a nerve we can check, and then we can, in a lot of nerves, we can also check the nerve gliding. You see here, this is the medial epicondyle. You see the cross-sectional area of an ulnar nerve. Here you see the triceps muscle and even a small anconeus epitrochlearis muscle. Now during flexion and extension of the elbow, you see here you see the medial epicondyle, and you see this ulnar nerve actually stays nicely within the sulcus. When you look at this example, you see here a more flat sulcus, and you see what this nerve is doing. He is jumping over the medial epicondyle, and everybody can gather that this nerve is not quite happy while doing this all the time during flexion and extension. The same we can watch at the wrist when we look during flexion and extension of our fingers. When you see here a section, this is the distal aspect of the radius, this is the proximal row. Here you see the structure of the tendons that is slightly different than the structure of the longitudinal structure of the nerve. You see here the median nerve, part of it, the retinaculum, and during flexion you see there are no muscle bellies within the carpal tunnel because they go proximal. Whereas during extension, here again the radius, the proximal row, you see here the flexor tendons, you see the deep flexor muscles, the superficial flexor muscles going slightly into the carpal tunnel. Here you see the median nerve and the retinaculum. You sometimes also watch lumbrical muscles, and this increases the volume in the carpal tunnel, leading to dynamic carpal tunnel syndrome. The cross section or the transverse section of the median nerve at the carpal tunnel is also a very helpful structure. You see here the pisiform, the ulnar artery in the center during the fist. You see the median nerve. Here is the tubercle of the scaphoid, the flexor carpi radialis. And what you see, this is the cross-sectional area right in the center when you do a fist. When you extend your fingers, you actually see that this cross-sectional area goes along to the radial side, to the scaphoid tubercle. About half of the transverse cross-sectional area moves to the radial or to the ulnar side during flexion and extension. This gives you a hint how mobile a nerve is during this movement. You also can watch that dynamically. You know already now this is our median nerve, and when we flex and extend the fingers, you see that a healthy nerve actually jumps around within the carpal tunnel when there is enough space around the flexor tendons. The same you can watch longitudinally. You see here again the longitudinal fibers, a little bit thickened epineurium and the flexor tendons. And when there is a normal gliding, you see about 2 to 3 centimeters gliding of the nerve along the flexor tendons with a normal movement. Nerves have actually all kinds of funny things to do. You see here again a median nerve in the distal forearm, and look what this nerve is doing while we trace it. It actually does a kind of asymptomatic somersault without any symptoms. It just fools us a little bit around, and you see there is no thickening, there is no indirect signs that this nerve is not happy doing it. You will later on see that nerves doing some things like that may be also pathologic. Now coming back to the median nerve in the carpal tunnel, you see here an unhappy median nerve. This one actually is not able to move around. There is a thickened epineurium and he cannot jump to the left and to the right. He is captured in the carpal tunnel, in the transverse section. In the longitudinal section, you may gather this nerve is here, and he actually gets stuck right here at the entrance of the carpal tunnel. So indirect, you get signs how healthy or how happy a nerve is during movement. So in summary, we have a typical pattern of the nerve, the epineurium that is hyperechogenic, white, and the axons that are white, and in between there is hypoechogenic fluid. We have the tendons and the muscles, and we can follow the longitudinal movement and the simultaneous gliding of nerves with tendons during flexion and extension. This is very nice to learn around the median nerve, but there are also other nerves we can experience that. And the transversal movement, the cross-sectional area with the ulnar and radial transposition of the nerve. So looking at the nerve, you always have to check the gliding, the longitudinal and the transversal movement in comparison to the other side in order to get enough information about this nerve. When we now move to actually scarred nerves or injured nerves, as I said, we have the neuromas, and we can follow also the postoperative course of a changed nerve. Here is an example of a patient who actually has this bump. He had several operations, several surgeries to the median nerve. In the sonography, here is the skin. You see there is quite a thickened bump here. There are some fascicles going through this bump, but there is a lot of scarring in the cross-sectional area. You might see it's like an explosion. There is not much left of a salami slice in this area, but a lot of scars. The operation, the surgery of this nerve showed this scar formation or this neuroma in continuity, median nerve proximally, median nerve distally. And we decided to reconstruct this nerve again with a nerve graft. Here you see it already covered by nerve protectors and tissue. I don't want to talk to you about the indication, just what the ultrasonography helps us here. Afterwards, we actually checked sonographically 5 months later the course of the nerve, and you see here the nice fibers. Then there is a bump again, and you can follow the nerve fibers distally. When you look at the cross-sectional area, you see here the median nerve, the salami slice, and when you look what this salami slice is doing, you see that there is not a normal structure here in between. And the patient was not better with pain again after this surgery. So we checked again, and this corresponded actually to this area, and we found the necrosis of our nerve graft with this, again, neuroma that was also histologically proven with actually an inflammatory process. So in this desperate situation, we actually decided to resect the nerve again and put some caprolactone wrap around it to avoid to get a new neuroma formation. And I want to show you again the sonography to that. You see here the caprolactone. This is the distal part of it. This is the proximal part of it corresponding to our intraoperative findings. And when we do the cross-sectional area of this nerve, you may see that there is the nerve, and here you see the caprolactone around the nerve proximally, no nerve, and then the caprolactone around the distal part of the nerve. What happens with time, you see here 14 months later, we still can gather here this caprolactone, but we don't see the shell anymore as good. More distally, we can gather it. It's a little bit more pronounced than proximally, but in the cross-sectional area, you see here the nerve again, but there is no shell around this. This has been resorbed. So ultrasonography may help you to follow your surgery in due course. And you see here the patient without having sensation after this second nerve resection, he is quite happy functional wise. So I think I want to just show you that ultrasonography helps you to follow your clinics, what happens inside. You see here another example for a morphologic change. You see here the nerve fibers of a digital nerve, and you can gather that there are no fascicles in between. You see here the fascicles proximal and distal. In the cross-sectional area, you see here no salami slice. And when you look at it dynamically, you see during fist, there is some tendon, lumbrical muscle, and some nerve, but the nerve is actually here also having not a nice pattern. However, the clinics shows that this patient with a neuroma in continuity, this was his index finger, has actually quite a nice sensation. He has no pain. So this morphologic changes actually that do not correspond to the bad clinic we would expect when we just see the sonography. So you only can interpret your sonography together with the clinical situation. This is another neuroma. This is an end neuroma. You see here the proximal part of the nerve, and here the hypoechogenic part of the end neuroma. When you look at the cross-sectional area, here is the neuroma along the cephalic vein at the upper arm. And when we follow that dynamically, you see the vein. Here the neuroma is coming, and here you see the nerve along the vein before it gets to a neuroma. This helps you to localize a neuroma with sonography apart from the tinel and the clinical signs. Another example of a primary neurorrhaphy, you see here a 90% lesion, again, of a median nerve that has been repaired microsurgically. And you see here sonographically, it's very nice with the high resolution. Nowadays, you can even see the 9-0 stitches here. You see the distal and the proximal nerve fibers. There is some part of a small area of scarring. And in the cross-sectional area, you see again the salami slice type of the pattern. And when you look at it, when we follow it, there is one piece where you don't see the salami slice is very good, but the rest is very nice structure. And this corresponds again with a good sensory and motor function of this median nerve lesion. Another example of a nerve graft. Here you have a neuroma in continuity, again over 3 centimeters of an ulnar nerve that has been grafted with cable grafts. You see the sonography preoperative. Here is your neuroma. There are no fascicles crossing this area. And the cross-sectional area is again without salami slices. And post-operatively, you can follow your reconstruction. Here you see the nice fascicles. There is maybe an area that is not so nice. Here are the sutures again, and distally the nerve has been can be followed again. And again, the nerve fibers in transversal section are also nicely visible. So in summary, interrupted patterns of nerve fibers in the longitudinal and the transversal area are very important signs for the changes of a nerve. It doesn't necessarily give you the function of it, as I said several times. You have to look for hyperechogenic edges of the epineurium and the surrounding of the nerves, and look also for the reduced or even abolished gliding capacity of the nerves that are you interested in. You have a good control of axonal pattern in distal nerve lesions, pre and post-op, but I think you have no more information with MR neurography in distal nerve lesions, as I mentioned before. And don't forget, you have no information about functionality of nerve fibers. Now, to the diagnostic and therapeutic infiltrations of nerve lesions, I only want to show you one example. This is a carpenter who had an ulnar nerve injury 13 years ago and has been grafted in the distal forearm of his left hand. And he actually had a quite nice motor function. You see here the first dorsal interosseous muscle and the intrinsics. He had quite nice sensation. You see here in this Semmes-Weinstein monofilament mapping, but he got over the years uncontrollable pain. You see here also the force. He has on his uninjured side 6 kilogram, and on his injured side 4 kilogram of the pinch force. Now, what do you want to know when someone comes to you with uncontrollable pain? You want to exclude this pain by a diagnostic infiltration in order to know whether this patient has only a sensory deficit after infiltration or also a complete motor deficit, and then you can plan more defined what you want to do. So you see here the ultrasonography. This is the ulnar nerve. Here was the neuroma. You see here the needle. This is the ulnar nerve. And we actually do an infiltration of the ulnar nerve proximal of this zone to get more information. You see here in the cross-sectional area, here is the nerve graft distally, and then you place your needle proximal to it, proximal to the nerve graft. And here is already your infiltration of your local anesthesia. This is the ulnar artery. Here is the ulnar nerve. After infiltration, this patient had no sensation, but still some pinch control. You see here the mapping again, no more sensation. So you must have some median nerve innervation of his intrinsics that gives you more confidence to do whatever you want to do a reconstructive procedure again. This is what we did. We actually reconstructed the nerve again. His sensory recovery was not anymore as good as beforehand. His force was also not as good, but he was get rid of his pain. You see here the longitudinal reconstruction of his new nerve graft, and in the cross-sectional area, there is some changes, but not really a huge neuroma. The second nerve I would like to share with you is the interosseous posterior nerve. We have very often irritative pain along with epicondylitis or with even wrist pain with the posterior interosseous nerve. And here, distal of the elbow, it's very nicely to infiltrate this nerve. You see here, this is the extensor muscle, the radial head, here the supinator muscle. And here actually lies the posterior interosseous nerve. And you can put your needle under sonographic control, and you can also then infiltrate your local anesthetic under sonographic control, and you get the local anesthetic there where you want it. The next chapter I would like to touch is entrapment or torsion of nerves. You have already seen an asymptomatic torsion of a nerve and two examples of nerve tumors where we see the limitations and the advantage of ultrasonography. This is a young lady with a hyperalgesia of the lateral cutaneous femoral nerve. And you see here the ultrasonography. This is the anterior iliac crest spine. And here you see where this nerve is coarse, there is a bit of a mess. And in the longitudinal sections, there is actually also the nerve not anymore going further down. This corresponds to allodynia in this area, hyperesthesia in this area of her anterolateral thigh. We did several infiltrations of this nerve and then operated on her, and we found an entrapped nerve in a suture of his previous hip surgery. We could actually free the nerve and just put an allowrap around it, and then post-operatively we could, this is a cross-sectional area of the cutaneous anterolateral femoral nerve, and you see now this nerve is again happy in this area where he had been captured. Another example is the radial nerve at the humerus. You see here the humerus cross-section. You see here the cross-section of the radial nerve that is far too small. In the longitudinal section, you see here the radial nerve, and you can gather there is a little dent. And when you put the cross-section of your nerve here, you have this volume, and proximal and distal is this volume. And what we found intraoperatively was corresponding to our sonographic finding. You see the torsion of the radial nerve at the distal humerus. So this is actually something you would not gather, you would not get in the MRI, because it's very difficult to get this slice in an MRI to get this finding. Here you are much more precise with your sonography. Now, last but not least, I would like to share the nerve tumors. You see here a bump distal of the axilla. This is the musculocutaneous nerve, and you see here a typical feature of a schwannoma. What is really important is that you look at the exit of your involved nerve with a schwannoma, and also the entry here in the axilla. It's not so easy to get that. And then you have your cross-sectional areas. You have seen earlier also the Doppler mode or the color mode, and you can check the vascularity of a tumor. You see here there are cysts. There are also calcifications around this, and this is the typical feature of ancient schwannoma. The more experience you get, you also can see the fascicles along the tumors. When you follow with your sonography, the fascicles with the sonography proximal and distal. However, there are limitations. Here I show you another schwannoma. This is actually the exit of the nerve. This was the common peroneal nerve. Here you see the schwannoma. This is quite big. And you see here we had an MRI because this schwannoma was nearly 8 centimeters, 8 square centimeters. And this is very difficult to picture with your probe that is only 3 centimeters long. You see here the cross-sectional area of the schwannoma. Here is the cross-sectional area in the sonography, and we have no chance. We pick about a tenth of the tumor. You see here the peroneal nerve only distally, but not proximally. And in the operation, you see this is a huge tumor. We actually were not able to resect it without sacrificing the peroneal nerve. That's why we just debulked it. And you see now after the debulking, you can see the entry of the peroneal nerve, the rest of the tumor shell, and the exit of the peroneal nerve. You can also look at the healthy side now with the cross-sectional area. This is the peroneal nerve at the same size location where you see it in the involved area. And now after debulking, you have a chance to follow the common peroneal nerve at the distal femur over the whole area. This is the femur here. And so in summary, we can localize nerve lesion, especially very small nerves, and we are independent from the course of the nerve with the sonography. We can also check the dynamic nerve gliding, as I tried to show you during active and passive motion. And we need to know that there is very often no correlation with our morphologic changes with the clinical function. It's very important to check that together. Not each neuroma must have a clinical bad function, as I have shown you. Sometimes it really correlates very well, but sometimes not. Nerve tumors over 3 square centimeters of size and untypical pattern, they are difficult to judge in the sonography here. You need an MRI. And torsions or neuritis of nerves, they are really difficult to recognize. It's getting a bit better with more experience. And all of these changes are subject to personal experience and interpretation, and it gets better when you compare it to the non-involved side. Thank you very much.